Buenas tardes. Hello, everybody. It's a great pleasure to be here. This is my second year in Mexico City with you, and I'm greatly honored by being invited again. I would like to thank the organizers on both the Médica Sur and Mayo Clinic side for inclusion in this symposium. So I was tasked with discussing management of low-grade gliomas. My talk will be much less futuristic than Dr. Bendok's, but it brings us a lot of joy to have all these phenomenal technologies on the horizon to be able to use them pretty soon. So as you probably already know, there is a revolution happening in neuro-oncology, and it's a really molecular revolution. 2016, a new WHO classification of brain tumors was published, and it really changed how we view brain tumors, and it also changed how we treat them. This edition of WHO classification, I call it a neuro-oncologist Bible. We all have it in our offices, and we frequently refer to this resource. Just not to summarize the whole book for you, I just wanted to kind of give you a snapshot of what really this new classification means for us in neuro-oncology. And as you can see from the slide, and we're going to be focusing on low-grade gliomas today, the major difference between the old classification and the new one is the molecular pathology. One change that you will notice is that oligoastrocytoma as an entity was really removed from the classification of brain tumors, and we really now have two major flavors of low-grade gliomas, one being an astrocytoma and the other one being an oligodendroglioma. The critical mutation that further divides them down is the IDH mutation. And we can have either mutated tumors or wild-type tumors, as you can see on the slide. Then they can be further classified by additional mutations. And you can see that in the IDH group, you can either have the 1p19q co-deleted tumors, and they automatically become oligodendrogliomas. So if you hear 1p19q deletion, immediately think oligodendroglioma. In the old days, we used this, it was always on tests, this kind of fried egg appearance on histology slide. Nowadays, it's not enough. You need to have a deletion to be able to call the tumor an oligodendroglioma. If you have an ATRX loss or TP53 mutation, then you're going to call it an astrocytoma. So that's the major difference. And of course, you have the IDH wild-type tumors that unfortunately are associated with much worse prognosis than the ones that have the IDH mutation. So before we go any further, let's quiz ourselves a little bit. So I'm posing you a question here. Which statement is false in terms of the tumor grading? Do we agree that non-enhancing tumors are often low grade? Is that true? Any takes on that question? Well, usually non-enhancing tumors are low grade, so that's sort of an indirect way for us to tell just from looking at the scan if the tumor is low grade or high grade. There's obviously there's a caveat with that, which I will tell you about in a moment. Enhancing tumors are always high grade. Is that true? Can we have an enhancing tumor that's a low grade? And the answer is yes, and I will try to show it to you in a few slides. The next one is the study based on spectroscopy, and I will show you some examples of that. Typically, high choline peak is associated with high-grade glioma, so this is a correct statement. And then finally, another imaging technique that we use in low-grade and high-grade gliomas is cerebral blood flow, and it's a helpful prognostic factor, especially in high-grade tumors. So let's review some examples. So this is an example of a non-enhancing tumor, and we are questioning ourselves, is this a low-grade or a high-grade tumor? And in this particular case, it was a case of gliomatosis. It involves more than one lobe of the brain. It was a grade 2 disease. However, remember that about 1/3 of non-enhancing tumors are high grade, so grade 3. So again, something to remember in the clinic when you're seeing a scan and discussing with the patient. Don't necessarily jump into the conclusion then the tumor is low grade if there's no enhancement. This is an example of a spectroscopy on a patient with a non-enhancing lesion. You can see right here is the tumor. Right here, no enhancement. Again, no enhancement. We did an MR spectroscopy on this particular case. You can see very high choline peak and also normal NNA peak. And based on the size of the choline peak and the choline creatinine ratio, this has been consistent with high-grade tumor, which on biopsy was shown to be an anaplastic astrocytoma. Another question that I asked you was, are enhancing tumors always high-grade? And this is an example of an enhancing tumor here with an enhancing nodule, cystic lesion. And what comes to mind when you see enhancement is high grade. However, in this particular case, this was a ganglioglioma, which is a low-grade disease. So again, imaging is very helpful, but you need to know that not everything that enhances is necessarily bad. MR spectroscopy can be used for low-grade gliomas as well, and this is a signature of a tumor that's of a lower grade. I showed you before an anaplastic astrocytoma that had a very high choline peak. This is not the case in this tumor. It's a relatively low choline peak and preserved NNA peak, which in this case indicated a low-grade astrocytoma. Perfusion is another way of assessing a grade of the tumor in a non-invasive way. And the low-grade tumors have a different signature on MR perfusion than high-grade. And this is, again, an example of a tumor here and corresponding perfusion, which on the scale here indicates decreased blood flow to the area, which is consistent with the low CBV ratio and, again, consistent with low-grade glioma. In high-grade gliomas, again, MR spectroscopy that you've seen before, high choline peak, consistent with high-grade tumor. And on a perfusion, you can see a different picture. So this is the tumor right here, and you can see the red dot. It's associated with very increased perfusion to that area of the brain with a very high CBV ratio, 4:1, consistent with high-grade tumor. Alrighty, so now let's move on to the update, the classification from 2016. On this slide, you basically have all, most of the low grades depicted. The easy way to kind of divide them is to divide them into the circumscribed tumors and sort of more diffuse disease. And these are all the entities in this category. They're mostly grade 1, and they typically associated with pretty good prognosis. Diffuse gliomas have now expanded. I mentioned before that there is no oligoastrocytoma anymore, so you only have astrocytoma and oligodendroglioma, but you classify them by IDH mutation. So it's critical to know what the IDH status is, and this should be in the pathology report. In oligodendrogliomas, which I mentioned before as well, the 1p19q deletion is the critical component. Other mutations that are commonly seen in low-grade gliomas are listed on this slide, and one particular one that I want you to remember is BRAF fusion in BRAF 600E mutation. And the reason why this is important is that there are drugs out there that are targeting this mutation. One such drug is called vemurafenib, is used for melanoma. And if you have a primary brain tumor that has failed other treatments, like such as surgery and radiation, you can potentially use BRAF inhibitor for your patient. So knowing if the mutation is present in the specimen is very important. Other mutations that are present in grade 2 disease include TP53, ATRX, as well as TERT. So these are things that you can look for and ask your pathologist to run additional testing on your tumor. So why am I telling you all this? I'm telling you all this because mutations are driving prognosis, and they're really important for you to know, and of course for the patient to know, and also for you to plan the treatment. And as you can see on this slide, a low-grade glioma with IDH mutation and 1p19q codeletion, which will be technically an oligodendroglioma, is associated with the best survival. The median survival is about 8 years, and these are the patients represented here by this curve. Then the next best is IDH mutation with no 1p19q codeletion 6.3 years. And of course, at the bottom of the spectrum is a glioblastoma with wild-type IDH with only very short survival. So again, knowing those mutations will inform you and your patient about the prognosis and would also allow you to select the treatment for your patient. So let's talk about some basics about low-grade gliomas. This continues to be a low-frequency disease, rare disease. This is how many cases it's being diagnosed in the US every year. These are usually younger patients. The tumors have typically characteristic MRI features, which I will show you in a moment. Almost 50%, almost half of the patients present with a seizure. So that's also pathognomonic for you to know that if you have a patient presenting with a seizure, they're sort of in the younger spectrum, 30, 40 years old, and they have an MRI suggestive of a glioma, it probably will end up being a low-grade tumor. There are prognostic factors that we use classically, one being age. The younger the patient, typically the better prognosis. The healthier the patient, so performance status, the better prognosis. The size, the smaller, and the location were all good prognostic factors. Nowadays, we have this new emerging prognostic factors that I told you about, including the IDH1 mutation, 1p19q co-deletion, as well as extent of surgery. Interestingly, when you look at the mutations in patients with low-grade gliomas, IDH mutants are more common in younger patients. This was the study with data from Mayo Clinic, UCSF, and the Cancer Genome Atlas, and you can see that the average age on patients with IDH mutation was somewhere between 30 and 40, while other patients with other mutations were older. So what does low-grade glioma look like on the MRI? We talked about kind of fancy imaging and spectroscopies and perfusions, but when you just get in a regular MRI, the low-grade glioma will typically be non-enhancing or maybe partially enhancing. You can have cystic areas. Frequently, we see them in the frontal lobe. They are typically positive on FLAIR. So these are the images that could represent a patient with a low-grade glioma. In terms of prognostic factors that I just discussed, we historically thought that age is a very strong prognostic factor. And again, younger patient, better prognosis. Proliferation index, similarly, if you have a low proliferation index in the tissue, the patient is going to do better. But now we found out, this was published in 2015, that in patients with IDH mutation, age doesn't really matter. So you can see here the patients over 40 and patients less than 40, the tumors that had IDH1 mutations, the survival was the same. So we need to really start changing our thinking about gliomas, and we see an older patient with an IDH1 mutation, the prognosis may be very good, and we don't necessarily have to be concerned too much about it. With mitotic index, the same. Even if you have high proliferation index in the pathology report, if the tumor is IDH1 mutated, this will really drive the prognosis, and the patient may still do very, very well. So how do we manage low-grade glioma? So this is a snapshot of options. Typically, we start with maximal safe resection, and I will tell you why. Surgery also has other additional benefits. If patients are symptomatic, we're debulking the lesion. We're trying to treat their symptoms. Sometimes we can actually treat seizures quite successfully in patients who are suffering from them. We, of course, need tissue for molecular testing, and surgery extends survival. Radiation has a significant place in treatment of low-grade gliomas, and we consider radiation for situations where surgery is not adequately treating the tumor, or we use radiation as an adjuvant. Also, some patients who cannot have extended surgery, like biopsy-only patients or subtotal resected patients, would definitely respond to radiation. Chemotherapy is becoming more and more popular in low-grade gliomas because of the recent investigations and studies, and it actually became a standard of care for a lot of our patients over the last several years. So how do you manage low-grade glioma? This is a slide from the National Comprehensive Cancer Network. This is an organization in the US that calls experts in the field, and this sort of guidelines are designed. So they're designed for different tumor types, including brain tumors. They are available online, and you can sign up to the website, and you can then view those guidelines. I find them very useful. They are being updated annually, so they're very much up to date. late, and they can walk you through the process of, what do you do with the patient when you potentially found a low-grade glioma. So in low-risk patients, so this would be your younger individuals, patients with IDH1 mutation, patients with gross total resections, it's still conceivable to observe, and this was something that we were doing in the old days in patients who had oligodendroglial tumors. They were in their 20s, that they had gross total resection. We wouldn't typically treat them with radiation right away. We would just watch them, and it's perfectly appropriate these days also to observe. The problem is with high-risk patients. And who are these high-risk patients? These are the patients who are typically older. These are the patients who have larger tumors, usually considered to be more than 5 centimeters. These are patients who did not have a complete resection. And these are also patients who don't have the IDH1 mutation. So these are the patients that you really want to go over the options, and then when you look at this, you realize that radiation and chemotherapy is basically the standard of care for high-risk low-grade glioma patients in 2018. I mentioned before that surgery is important. We knew this from high-grade literature, but now we know that in low-grade tumors, surgery is equally important. An extent of resection is strongly associated with survival. So these are two separate studies. The patients in the upper curve are the ones that had gross total resections. The patient in the blue curve here and the black one here are the ones that had a subtotal resection. And you can see significant benefit of surgery in both cases. Resections can sometimes be tricky, and Dr. Bendock showed you some, and will show you more beautiful technologies. How can we make resection more defined? How can we make it safer? I think we're getting better at getting low-grade gliomas out of patients' brains. The next step following surgery is typically radiation, and there's been an ongoing debate over the last several decades, what is the best dose of radiation to give to a brain tumor patient with low-grade glioma. And it has been established recently that a dose of about 50.4 gray in 28 fraction is the way to go. You don't necessarily need higher doses that are more toxic, and in multiple studies it was not shown that higher doses are necessarily beneficial. There are new technologies, specifically proton beam therapy, that we are fortunate to have at the Mayo Clinic in Arizona, that at least hypothetically cause less damage to the healthy brain, and we are utilizing more and more proton therapy in low-grade tumor patients. Of course, we need clinical trials to prove that, and they are being designed. The timing of radiation is critical. We know that radiation increases progression-free survival, but in terms of when to do it, the studies show that early or delayed radiation, there's no difference in overall survival. So if you do radiation to the patient now versus 5 years from now, the patient is still going to live the same amount of time. However, you may change progression-free survival, and also in patients who have symptoms, let's say somebody is having seizures, cannot have surgery, radiation can also offer symptom control. So you really need to decide about radiation on case-by-case basis. And these pictures just show you that early radiation improves progression-free survival for patients. However, overall survival does not differ between early and late radiation. I think we need to be aware of the fact that radiation is not completely benign to the brain. And that's the question, early versus late. And you have an example of a patient here, 35 years old, patient IDH mutated, 1p19q co-deleted, so good prognosis patient, diagnosed in 2000, treated with radiation chemotherapy, and now 14 years later, you can see that there's no tumor progression, but you see all this post-radiation changes that frequently go along with symptoms, predominantly cognitive decline, psychomotor slowing, and other difficulties. So if you're treating somebody at a younger age when they are expected to be productive and have a career and work and have a family, if you do radiation too early, then you can be dealing with a lot of complications for this patient who is doing well from the glioma standpoint, but unfortunately has complications. Role of chemotherapy in low-grade tumors has increased recently. Again, we used to use surgery and chemotherapy first, but now we know that chemotherapy makes a huge difference. As you can see from this particular study run by RTOG that randomized patients to radiation alone with radiation with PCV, which is a combination of 3 drugs, procarbazine, vincristine, and CCNU, you can see that median survival is significantly improved, and it's almost double, right? So radiation alone alone, patients live about 7.8 years. If you do radiation followed by chemotherapy, the survival goes up to 13.3 years. So this is a huge discovery, which really changed the way we treat low-grade gliomas nowadays. And most patients, especially in the high-risk, low-grade group, will be considered for chemotherapy. So when you're thinking about chemotherapy for low-grade tumor patients, you need to use the molecular data. So definitely make sure that you have all of this in the pathology report. And most of these tests are available clinically. We now know that adjuvant PCV offers survival benefit for newly diagnosed patients. The big question that we all have in neuro-oncology is, what about temozolomide? Can we use temozolomide instead of PCV? Because as you all know, temozolomide is much less toxic. It's much more easier for the patient to take. So we do have data from grade 3 gliomas, anaplastic gliomas. It was a Catnon study when radiation was used with temozolomide and temozolomide alone. And in this study, it was found that the radiation and temozolomide is better. So we know that at least for this group of patients, using this approach is appropriate. The big question is going to be answered by this study, a CODEL study that's looking at 1p19q co-deleted tumors, and it's randomizing radiation with temozolomide versus radiation of PCV. So this is the study we're really waiting for the results for, because it will allow us to finally say, you know, should we abandon PCV completely and move to temozolomide, or maybe temozolomide will be inferior. So it's going to be a few years before we find out. In terms of clinical practice, it's a little bit of a personal preference. I like to follow the data, so I offer PCV to most of my patients. Usually we make a decision together. If the patient is averse, side effect averse, then we typically go with temozolomide even though we don't have the data yet. Some patients decide to, again, go with the data and try PCV, and it can be successfully done. It's pretty rough on the patients and affects quality of life in a significant way, but you can pull the patient through this. The group of patients that are tough to treat are IDH wild-type tumors. So these are the patients that have a lack of this mutation. These are molecularly heterogeneous patients. They typically have high proliferation index and TERT mutations, and they really behave like GBMs. We don't have good treatments for these patients. There is a lot of experimentation using radiation with PCV, but also using sort of other newer approaches to this group of patients. But if you have a patient with wild-type low-grade glioma, think about this as potentially glioblastoma and treat them as aggressively as you can. When low-grade tumors progress, that becomes a problem for all of us in neuro-oncology. NCCN guidelines, again, have a paradigm in terms of what to do when your tumor progresses. And there are two distinct groups of patients. These are patients that have previously been treated with radiation, and there are patients that have not had radiation. And the pathway is slightly different. I think that the patients that had radiation for low-grade glioma and then you see progression, I like to sometimes do a biopsy if it's possible to see if the tumor has changed grade. Is it now grade 3? Is it now grade 4? It also can be sometimes deducted from imaging, but surgical resection or biopsy is frequently recommended. And then depending on what you find, you choose typically chemotherapy option. You can sometimes consider second course of radiation if the patient can tolerate it. If the patient has not had radiation, then your options are a little bit more open. The patient can have surgery where the tumor is resectable, similarly to this particular case, although surgeries in these patients are more challenging. And then, of course, you're going to have radiation as an option. So whatever you do prior, you're always going to recommend radiation. And because of what I just told you in the past few minutes, we know that radiation by itself is not good enough, so you can use radiation with PCV or radiation with temozolomide. So to summarize my talk, the 2016 classification definitely changed the way we view gliomas. Keep in mind that about 90% of low-grade gliomas are IDH1 mutated. Distinguish different categories of gliomas. So, again, look at your pathologist to tell you what, I think we lost power, to tell you what the molecular flavor of the tumor is. IDH wild-type tumors are aggressive and behave like GBM. Aggressive surgery for low-grade gliomas is definitely mandatory. Keep in mind that radiation improves progression-free survival, and decision about using radiation is very individual, early versus late. And also keep in mind that chemotherapy now is a mainstay of treatment for low-grade gliomas. So with that, I would like to thank you and show you a picture of my dear friends, Dr. Pineda, Dr. Zavala, and Dr. Bendock. We were here last year, and we had a phenomenal dinner together at the Azuli Oro, and I still remember it to this day. And thank you for your attention.